Hello, everyone. Good afternoon. My name is Megan Lacey Young. I'm the Manager of Quality Improvement and Process Review for the Center of Women and Infants. And I'm here to co-present with Dr. Nikki Zite, who is a professor and vice chair of Education and Advocacy for the Department of OBGYN here in Knoxville. Today, we're going to talk about trends in healthcare access across Tennessee and explain the impact of decreased healthcare access on family planning. We're going to highlight the role of contraception and then discuss disparities across these topics. We have no disclosures. We know that since 2010, Tennessee has experienced 16 hospital closures, and the majority of those are rural. This is the second highest rate in the United States. Recently, there was a report that came out in February of this year that said 41% of rural hospitals in Tennessee are at risk for closing, and that's up from the prediction of 23% in 2019. These closures increase the vulnerability of communities and further strain existing hospitals. I know we've certainly felt that in women and infants as our delivery volume has increased, and in 1 year of closures, it increased 150%. So it's certainly something that does exacerbate existing systems. Not only does this impact primary care access, you can see that Tennessee, we had a rating of 7. Tennessee overall was a rating of 7, but some counties are up to almost 20. On this scale from the Sycamore Institute, which looked at access to different healthcare providers, specifically primary care providers per 10,000 residents. In the maternal health side, there's other metrics to measure maternal care access. The March of Dimes has given a rating to different counties. This rating accumulates into overall maternity care access, but looks at access to OB providers and then access to hospitals with an OB care or birth facility within the county. So there's maternity care desert is 0 access. Then you have different, at the different levels, you have low access, moderate access, and full access. Overall in Tennessee, 33% of counties are considered maternity care deserts, and 17% of women have received no or inadequate prenatal care. This is higher than the national average. Almost a third of women in our state have no birthing facility within 30 minutes of where they live, which is 3 times higher than the national average. Women in Tennessee who live in maternity care access or maternity care deserts travel 2.1 times further than women who live in full access areas. And their average distance that they have to travel is about 16 miles to a delivery facility. Across the state, the highest range in which women have to travel is about 65 minutes to 71 minutes, which I don't know about your all's experience with prenatal care, but prenatal care is time consuming in itself. And I was lucky enough to have prenatal care in the same facility in which I work. So I can't imagine having to tack on an extra hour to and from my appointments. Not only is maternity care access limited and very sparse in Tennessee, but we also have the issue of that's exacerbated by restrictions on reproductive health. In our state, that this contributes to a decrease in desire for new trainees to want to come here to learn because they can't learn the full scope of practice that they need in the real world to deal with miscarriage management and other types of situations. And as abortion laws increase in their restrictions, maternity care suffers, not only in the time point where women are pregnant or are theoretically able to be pregnant, but also across the full spectrum of their care. So this is what we call the ripple effect. As physicians leave the state or choose not to come to train here, this does impact ability for physicians to learn and be able to provide miscarriage management, learn and be able to provide ectopic pregnancy management, and it limits the ability for women to access gynecological care throughout the course of their life. In the service area of UT Knoxville, you can see here is a map of our access to OB providers per 10,000 births. And this is one of the components that make up maternity care access overall. Here is our access of to OB care or birthing facilities. And then overall, here are the counties that have full, low, or are considered maternity care deserts in our service area. This problem then feeds into maternal morbidity and mortality. So specific to maternal mortality, that's a measure of a mortality that occurs during pregnancy or within 1 year from delivery. There's 3 different types of maternal mortality. One is pregnancy-associated death, which is any cause of a death within the pregnancy or a year from delivery. Then there's pregnancy-related deaths, which is a pregnancy complication or a chain of events initiated by pregnancy that causes death. Pregnancy-associated but not related deaths are a cause of death that are related, that are not related to pregnancy. Over the last several years, the rate of maternal mortality in Tennessee has increased, and especially so when compared to the national average. In 2021, this is our most recent pregnancy, maternal morbidity and mortality report. 53 women in Tennessee died from pregnancy-related causes, and the burden was most heavily felt in our non-Hispanic Black women who were covered by TennCare and resided in West Tennessee. The 3 leading causes of pregnancy-related death were COVID-19, cardiovascular disease, and substance use disorder. Obesity contributed to 1 in 3 pregnancy-related deaths, and mental health contributed to 1 in a third of them as well. Substance use disorder was a contributing factor in 1 in 3 of pregnancy-related deaths, and most pregnancy-related deaths that are reviewed are deemed preventable, with 2 in 5 having a good chance of being prevented. From 2017 to 2021, 166 Tennessee women have died during pregnancy or within the year of following pregnancy from causes related to or aggravated by pregnancy. These pregnancy-related deaths accounted for 36% of all pregnancy-related deaths between 2017 and 2021. The proportion of pregnancy-related deaths has increased over the past 5 years, and from 28% to 40%, and we continue to see a trend of non-Hispanic Black women dying 2 times more than non-Hispanic white women. And then women aged 30 to 39 are 2 times more likely to die than younger women. Women with TennCare are twice as likely to die than women with private insurance. And women in West Tennessee have a higher ratio of pregnancy-related deaths than women in other Grand divisions. COVID impacted the lives of 22 women during pregnancy or within the year of pregnancy. Over half of these deaths occurred in the postpartum period. About 4 in 5 of these women who died from COVID-19 were unvaccinated, and 4 in 5 of the COVID deaths were pregnancy-related. Most COVID-19 deaths were deemed preventable. Obesity contributed to almost 2 in 3 pregnancy-related COVID-19 deaths, and COVID-19 deaths occurred more among metro residents than in rural residents. When it comes to pregnancy-associated but not related deaths, 63 women died from pregnancy-associated causes. Over half of these women were under the age of 30 and non-Hispanic white. The key takeaways from these deaths include acute overdose as a leading cause of death. 2 in 3 of these deaths were deemed preventable, and substance use disorder was a contributing factor to almost 3 in 5 deaths. Mental health and the lack of ability to access mental health also contributed to a third of these deaths. In 2021, 63 individuals died from pregnancy-associated but not related deaths, causes, I should say. These deaths accounted for half of all deaths, and most deaths occurred in the postpartum period. These mostly occurred among non-Hispanic white women and women under the age of 30 and with public insurance. Dr. Zite, did you want to talk about teen birth?
Always. As Megan mentioned, I'm Nikki Zite, and I am a OBGYN here at University of Tennessee in Knoxville. I was on overnight last night and got to deliver some babies. And I don't think that we did have a teen birth while I was on last night, but I do feel like we are seeing an increase in teen pregnancy and teen birth, and we'll talk a little bit about why we think we're seeing that, and just in general how Tennessee is doing with teen birth and teen pregnancy. As you can see from this slide, a little spoiler, we're not doing well. You can see that we rank 7th among the states, and this is one of those situations where you don't want to be in the top 10. You would like to be 50 or in the bottom, because high teen birth rate is not desirable. And we sit at about 23.3 per 10,000 teenagers. Okay. Want to advance? Yeah. So this slide demonstrates the results of a survey asking public health experts what they felt were the most important health factors impacting rural counties in Tennessee. And almost outstandingly, these counties felt like teen pregnancy was one of their biggest issues. And despite teen pregnancy being one of the biggest issues, we don't have a statewide strategy to address teen pregnancy or teen birth. In fact, if you see things that are going on with our legislation related to sex ed, contraceptive access, and things that have been shown to decrease teen pregnancy and teen birth, we don't seem to actually feel like teen pregnancy is one of the biggest public health factors, or at least the people who are making the rules don't seem to think that teen pregnancy is one of the biggest factors, or that the evidence-based strategies to deal with teen pregnancy and teen birth are not being applied in Tennessee, or would not work in Tennessee. Seems to be the feeling of people making those decisions. Megan, sorry. So if you remember some of the maps that Megan showed you earlier, if you kind of overlaid them, a lot of the same issues with access to care relate to teen pregnancy and the rates across the state. You can look at your county or different counties and see, but this was the teen pregnancy rate, different than the teen birth rate, but the average here was 27.3. Again, not doing well where we would want, or where we would want to be. And this is the teen birth rate. So you can, from the last slide, if you remember, it was 27-ish for teen pregnancy. Not all pregnancies go on to be births. There's miscarriage, there's abortion. And so that accounts for the difference between our teen pregnancy and our teen birth rate. But what you'll see in some of the next slides is that Tennessee doesn't have as big of a difference between the teen pregnancy rate and the teen birth rate as some other states. And that is because our teenagers access abortion as a way to end their pregnancy less often than some other states. And that may be access, that may be a true desire to parent, it may be other issues, but we are 10th in teen pregnancy and 7th in teen birth. So again, worse in birth because in some other states, teenagers are choosing not to stay pregnant once they're pregnant. And if miscarriage were that difference, we would expect the miscarriage rate to be similar across states. So we really do attribute most of that to utilization and access to abortion care. We do know that contraceptive access could decrease both teen pregnancy and teen birth, and we would like to see that continue, and that's where our team is putting most of our efforts. Again, this shows the teen birth rankings, and that Tennessee, this is one of the where they flipped the measurements on us, but this is where the higher numbers are less desirable. And we were 40th out of 50. And then in 2021, we were 44th out of 50. So going in the wrong directions, as other states may be making some progress in their teen birth rates, we were not in Tennessee. So one study that we focused on to help us kind of address what we thought would be a solution to some of our teen pregnancy and just undesired pregnancy overall in Tennessee was the Contraceptive Choice Project. And this study was done in the early 2000s to 2010s and essentially provided patients with whatever contraception they desired. They made their choice regardless of their ability to pay for it. And they removed the barriers, gave them standardized counseling, and what they saw was that when you remove those barriers, most women chose what we call LARC, or long-acting reversible contraception. So these are your contraceptive arm implants or your intrauterine devices. These are your contraceptive methods that are, for lack of a better term, set it and forget it, where patients don't have to remember them every day, like with a pill or with every active intercourse with condoms. So they tend to have very high efficacy, or at least the difference between perfect use and actual use is very small, because once it is in place, it is effective. So overall, not only did a lot of women in the study choose these methods, but they chose to continue them. They were satisfied with them. On average, when you look at a contraceptive new start, someone who chooses to start our short-acting methods like the pill, the patch, or the ring, less than 50% are still using them at 1 year. And whether that's because they had a side effect with the method they didn't like, they struggled to get to the pharmacy and get that method every month or every 3 months as required. When you looked at that compared to LARC, those patients who had a method implanted by a provider were 82 to 80%, 86% still using those methods, highly effective methods, at 12 months. At 24 months, those continuing LARC were 66% for those who had not had a baby in the past, including those 14 to 19 years old, and 76% for those who had had a baby. At 12 to 24 months, not having had a baby was associated with a slightly higher risk of discontinuing the copper IUD and the arm implant. But again, the overall numbers of continuation were still excellent. And the age alone was not associated with contraceptive discontinuation. So our teenage patients were satisfied with those methods overall and were continuing those methods. When they broke out just those younger patients, there were 863 in the study. Most of them had not had a baby yet, and it was almost 50-50 for choosing an intrauterine contraceptive option or an arm implant. And so making all these options available to patients and even to your teenage patients would ideally improve contraceptive satisfaction and contraceptive continuation. Another study that really focused on those teenage patients was the CAMP study, or the Colorado Adolescent Maternity Program. This program only offered the contraceptive implant, so IUDs were not an option, but they offered these teenagers, while they were during their delivery admission, the opportunity to have a contraceptive arm implant placed, or they could elect an arm implant at a later time or a different contraceptive method at a different time. And of the 396 teenagers or young women that they enrolled in the study, 171 had an arm implant placed immediate postpartum, and 225 chose another method. So I'm sorry, this slide is small and busy, but essentially it's showing contraception continuation with method of choice. And if you just look at a year, those who were in the control group, those are the people who did not choose to have their arm implant placed immediately, versus those who were in the immediate group. You had 86% still using the arm implant at 12 months versus 21%. And then if you look at all contraceptive options, more patients were using no method at 12 months in that control group. It's down at the bottom there, Megan, but 12% were using no method in that group that did not get contraception, and none in the group that had that early access to the arm implant. So when teens were offered an immediate postpartum option, they chose to elect to have that option placed. They continued the option for at least 24 months. And most importantly, they had fewer repeat pregnancies within 12 months. Of those who selected the immediate postpartum implant, there were only 2.6 short interval pregnancies or pregnancies within 12 months. Of those who did not select the immediate postpartum implant, almost 20% had a pregnancy within a year. And remember, these are teenagers. So we're having teenagers with now multiple pregnancies. So we used this information to talk to our TennCare partners and the insurance companies, and advocated for immediate postpartum contraception to be available at the University of Tennessee and across the state of Tennessee. And Megan and I were both part of the group petitioning TennCare to get this option available, and then rolling out this option across the state once TennCare in October of 27 announced the change in policy, and that policy went into place in November of 2017. I don't know what number I just said a minute ago, but 2017. We led the Tennessee Perinatal Quality Collaborative Quality Improvement Project on helping labor and delivery units across the state implement an immediate postpartum LARC program that took place from 2018, so shortly after the policy change, to the end of that year. At the end of the project, 6 delivery institutions offered IPP LARC. Unfortunately, we'd like that number to be much bigger, but that was still considered a win because 3 of those were very high volume delivery institutions, one in West Tennessee, one in Middle Tennessee, and us. And you can see that over time, a significant number of immediate postpartum LARCs were available to patients and placed in patients. It's important to note, sorry, going back to that, we did want to emphasize that making this option available to patients, we were only able to make it available to patients who had TennCare for their insurance coverage. And we really wanted to emphasize that these were patients who wanted that option. We had to have a strong emphasis on not coercing patients or saying, oh my God, you're a teenager, you need this option. These had to be patients who desired these options. And so there were balancing measures within the project to make sure that number of devices placed alone was not our metric. It was number of devices placed in desiring patients was our metric. So one of the other things that we have tried to look at is really access to care based on other indicators of health disparities. And the Area Deprivation Index was created by the Wisconsin School of Medicine and Public Health to try and hone in a little more detail than some of the other metrics that we've used. We often will use average income by zip code, but even if you look at just our zip codes around Knoxville, 37919, 37920, there is a really big range of incomes within that zip code and a really big range of access to care. So people are trying to create something that gives us a better indicator of access to care and how people are able to access care. So area deprivation index was something else that we became aware of and interested in looking at how that correlated to access to contraceptive services. So we started looking at it. And so we had a resident who looked at the access to the rate of adolescent pregnancy based on area deprivation index. And we looked at our deliveries over the period of time from March 18th to June of 2023. And when we looked at just our deliveries in those under 20, it was about 5.8% of our deliveries, or about 1,300 girls. And then we were using the recommended cutoff of 75 as the area deprivation having less access to care. And we showed that 52% of adolescent births were occurring in regions with that decreased access or an area deprivation index of greater than 75. And then when we specifically looked at repeat births, again, those people who were not finding access to contraception after they had one pregnancy, we saw an increase in repeat births in a higher, in a more deprived area. These patients also had less prenatal care, which we think contributes to some of what Megan discussed earlier, some of our maternal morbidity and mortality. But because our numbers were so small, it was hard to show significance. And these are just a little bit more in a different visual way to visualize, but we had, if you were in a more deprived area or had an area deprivation index of greater than 75, you were less likely to get prenatal care, more likely to have limited, late, or no prenatal care. You were more likely to have one birth and more likely to have additional births. And again, these were not statistically significant because they were small numbers, but we do think that it's a possibility we could see with larger numbers some significance. We also wanted to look at that short interval birth. So births occurring less than 2 years apart, and how that related to whether or not a patient had access to that immediate postpartum long-acting reversible contraception. So again, our table is a little hard to see, but we started this in July. This is a small evaluation of our project with 276 patients being looked at, both at birth certificate record and our delivery records, and whether they were able to obtain IPP LARC. And then we looked at birth certificate records for 24 months before they had LARC placed to see if they had a previous short interval birth, and then birth certificate records for 24 months after they had LARC placed. And in this small population of patients, there were 23, almost 24% short interval births prior to LARC, and only 4.2% short interval births after LARC. So we are working on better ways to analyze this and larger data sets. We now have acquired actual TennCare billing data for the time period that we've been able to offer immediate postpartum LARC, and birth certificate records for up to 2 years after. So we will be able to really show the impact of access to immediate postpartum LARC in patients who are able to obtain it on short interval birth. So in summary, many Tennesseans lack access to healthcare, including contraception. When you don't have that access, you find unacceptable rates of maternal mortality and morbidity, in unacceptable rates of short interval births, and unacceptable rates of teen pregnancy and teen birth. Access to contraception can decrease the abortion rate and also the teen birth and the teen pregnancy rate. and access to contraception can decrease the maternal mortality rate. If we were able to do a better job with our planned pregnancies, optimizing healthcare prior to pregnancy, we believe that we would see an improvement in our maternal mortality. So we'd like to open this up to discussion. We really have quite a bit of time, and we hope that some of you either have questions or comments on these topics. Or you can listen to me talk more because I can talk about this forever. Hi, Dr. Shepard.
Hey, how are you?
I'm great. Dr. Shepard is one of our fabulous colleagues from across the state in Memphis. She was one of the attendings that helped train me when I was a resident in Memphis. Thanks for coming.
Thanks for inviting me, and thanks for a wonderful presentation. Of course, this is something that is very near and dear to my heart. One of the reasons I stayed in Memphis was to stamp out teen pregnancy, and of course, we're still working on that. When we present data like this, it's somewhat discouraging. And thanks for the area deprivation index. That's a neat tool to really look at things. What for Tennessee, based on what you've presented, access to contraception takes care of a lot of things for us. Given some of the hesitation that we seem to have in different communities, what have you found works? We've been promoting immediate postpartum LARCs, and I think that has helped us a lot. But what you shared was, we're in Memphis, outside of Memphis, the counties between here and Nashville, between Nashville and Knoxville, those are the areas that we really probably need to focus on. How can we get the message there to providers such as they have to school systems? What would work in our state?
Yeah, well, you pointed out one of the big barriers, because we are not allowed to talk about these things within the school systems at all. If a school nurse in our state found out that one of her students was about to embark in sexual activity or participating in sexual activity and was not contracepted, my understanding is that if she directed that student to contraceptive services or spoke about contraception, she could risk her job and potentially some of her school funding, because we essentially have a gag order discussing anything about sex or sex adjacent things like contraception in the state. So we've created a situation where we can't give the information. I can't tell you for sure that if we gave the information that everyone would take us up on it. We're also living in a world of social media, and a lot of distressing stuff is coming out lately that I thought we had already passed, with myths and misperceptions about contraception. It is interesting in medicine, if you live long enough, you see all the peaks and troughs. And when I trained with you, we actually didn't have a contraceptive implant available, and we had one IUD available that was a 1-year device. Now we have 5 IUDs available and our contraceptive implant, and we had gotten up to the point where 15% of contraceptors across the board were electing some of these options. And now we're seeing for the first time it either leveling off or decreasing. And a lot of people think it's related to TikTok or social media videos that are very negative about hormones and hormonal contraception. So I think we need to come back and fight these things with the same modalities. I'm not going to become a TikTok star, but I think we have some residents, both in your program and mine, who would be relatable to some of these patients and could start speaking out about, it's easy to get on social media and do the negative, but what's the positive, and why don't people talk about the positives? And I think maybe that would resonate. And then, of course, we just need to make sure that barriers like cost. We know that there are some physicians who would like to be providing LARC more often, but struggle to keep it on the shelves in their office because these devices are expensive. So TennCare has come up with a vending machine-like product where the office can have the vending machine in their office and they don't pay for the devices until it's billed to the patient's insurance and they use the device. So we need creative measures like that to increase access. And frankly, without Megan, we would not have had a successful IPP LARC program at our institution. You need a champion. You need someone who can dedicate the time and the effort. And that's probably not going to be our busy clinicians. We need to find funding for people who are passionate about this and can interface with the physicians, the nurses, the IT people, the pharmacy people, and all the different stakeholders that it requires to start a successful IPP LARC program. But we do see more programs popping up across the state, and so maybe we will have some more labor and delivery units using this option or making this option available to our patients. I
Definitely.
know that there's a question in the chat about counseling tools and measures that are ideal with adolescent populations. I don't know if there's one thing that works for any population anytime, but I do think that bedsider tends to be a useful tool that we often will send people to. And I think that people are working on these things. I would love to see some peer counseling and some programs, again, where we were allowed to go into the school or we worked out within the barriers and did after school programs. When I was a resident, we went and we talked about smoking. I would say that maybe pregnancy is as much or more of a risk than smoking or vaping for some of our patients. And so we could create things like Don't Choke on Smoke or the programs that we used to go educate kids. We were able to go into the schools for those things, but we're going to have to be creative and do them at after school programs or ways that we can.
Dr. Zite, there's another comment in the chat, wondering if there's information on studies about contraception access offered after a miscarriage among adolescents.
Ooh, that's a great question. I will have to look that up. If you I'll put my email in the chat, so that you can email me, and we can look that up together, or I can reach out to some of my complex family planning colleagues and see what they're doing. We have a lot of information on access to contraception after first trimester abortion, and they do look at some of that with teens. But I don't know how much we have with miscarriage management. I will say that once you have a program like immediate postpartum contraception in your facility, you have the devices in your facility. So we have found that we are using those devices after pregnancy loss as well as after term pregnancies. And that is a great addition to that program.
I'll add another plug that if anybody has contacts with private MCOs, it would be great to allow women with private insurance to have access to all contraception during their delivery hospitalization. Currently in Tennessee, this is still only available for women with Medicaid.
We'd love to hear from more of you because we definitely have more time. Otherwise, I'm going to pull up more of my research. I don't want to torture y'all with that. I think that there's probably some interesting correlation to some of the other things that we're seeing. I think I saw some of our NICU folks, increase in STIs, both in our pregnant patients, and we're seeing more, neonatal syphilis and other things. And I do think that all of this conversation overlaps, and lack of education and lack of access to care are playing a role in all of these unfortunate things that we're seeing. So when you look at teenage pregnancy, do you break it out by planned, unplanned, single, or married? There may be, again, it's often very, very small numbers, and I'm not sure that that is even like single versus married. It would be, were they married when they conceived? Were they made to get married because they conceived? I don't think I think that's very hard to look at. And planned versus unplanned is also both a challenging and what we're working on, trying to figure out planned versus unplanned, acceptable versus unacceptable. And that's one of my other projects that we're partnering with the University of Pittsburgh and UCSF. Because while some of these teenagers are not planning pregnancy, they're also not preventing, and they also don't see pregnancy as the huge negative that, for example, I would have seen it as when I was a teenager. And some of that is what is culturally acceptable, what their outlook is on their future. And I mean, we've seen it from some of these shows like 16 and Pregnant. They think of these pregnancies as positive because it will be unconditional love. It's something else that they're missing, or they will start getting other support, or people will pay attention to them. So there's so many nuances that just looking at planned, unplanned, married, or single doesn't really help. And we've got to really figure out what measures we should be looking at and how. And I would say things like, can you support the child financially, emotionally, and how do you look at that? Are you able to continue your education and reach goals that you had set for yourself? Did you set goals? Are you in a situation where you even think you are strong enough or have the ability to set goals? Are you in an abusive relationship? Do you stay in an abusive relationship because you now have a child? So there are a lot of other metrics that we think are important to look at, and that we would like to look at to answer some of these questions. I'd like to find the question that actually moves the needle in making people want to address this with things that have worked in other states. Because I think we have plenty of data that shows we should be working on this in this state, and we're not. Dr. Shepherd, did you have another comment or suggestion?
Yes, I was just mentioning that in the College of Medicine, we have a student group called Student to Student, and they are able to go into the public high schools, a few high schools, to address the issue of sexually transmitted infections. And they've been doing this for at least six years, I believe. Okay. And it's very, the prompts, the PowerPoints, everything has to be approved by the school board. But that is one, and hopefully those conversations can lead to others, but definitely contraception is not even spoken there. But because of the high rates of STIs among adolescents, they felt it was enough of a problem to allow this conversation. So
that's great. We'll have to learn more about that and see if there is a chapter at UTK or whether or not UTMC can look into something like that. Where I think that, we have these young learners who are really passionate about these topics and are often looking for outlets for that passion. So are there any counselors that speak Spanish and understand the nuances of Hispanic culture? That's a great question. I do think they are out there. I don't know that we have that here in Knoxville. The group that I work with at Pittsburgh and San Francisco, our site for most of the Hispanic patients work was in San Francisco, and we did learn that there were cultural differences that cause statistically significant differences in patients' understanding and desires for contraception. So I do think that that's important. We are expanding our translating services, but you're right, that doesn't always get to nuances of culture. and that is important. The decision aid that we just created for permanent contraceptive decision-making was looked at in Spanish, and we are evaluating our Spanish-speaking patients who utilize that decision aid, and that data will be forthcoming. Megan, you've looked at the chat. I'm not missing anyone else, am I?
I don't think so. There was a request to hear more about your research. And then I did wonder if we thought maybe Cherokee would be a good Knoxville resource.
Yeah,
Not sure
certainly
about
for
numbers.
Spanish-speaking patients, I think we have the most Spanish-speaking providers within the Cherokee Health System.
Mhm.
And they do provide, they have women health providers, both for prenatal care and for contraceptive services. So that is a good resource. And they partner with us for their delivery here, and they are offering those patients immediate postpartum LARC. And given the changes in Title X and the fact that a lot of those patients do not qualify for extended Medicaid out to 12 months postpartum, they are making sure that those patients truly understand the option of IPP LARC and getting contraceptive access at the time of their delivery.
Well, if we don't have any more questions, we can go ahead and say thank you for presenting for us.
That's great. And you do have our emails, and you can reach out if you have other research ideas, if you want to hear more. Certainly, if you have ideas for how to dispel some of the myths, or like the question that Dr. Shepherd asked, or access to programs that help us with counseling and access, we are always interested. I'm always amazed that despite the fact that I've been doing this work for so long, I'm not aware of half of what's going on out there. And I'd rather we not work in our silos where, our public health experts are separated from our physicians. We need to really integrate to fight these fights. Thank you.